All right. Patricia emailed. She emailed us through questions@askjoedimatteo.com. If you have a question, send it to questions@askjoedimatteo.com. She said, is there anything that can help hot nodules in the thyroid causing subclinical hypothyroidism? Her TSH is low, but the rest of the thyroid hormones are normal. Graves, etc., have been negative. Only options she was given was, say it for me, methimazole, radioactive iodine, or removal of the thyroid. Mm-hmm. Okay, so we've talked about this before, but briefly, the thyroid is...
Yeah. Yes. It's a gland. It's in the neck. It's below the Adam's apple. It's technically an endocrine gland, meaning it's secreting hormones directly into the blood.
Okay.
It secretes T4, T3.
Right.
Calcitonin, peptide hormone are the main three.
Okay. All right. And what is a hot nodule?
Yeah. So looking at a hot nodule, by definition, like let's say, for example, radioactive material is used to examine the thyroid, like in a scanner.
Okay.
These nodules will collect more radioactive material than like the surrounding thyroid tissue. And so when that happens, these are considered hot, so to speak. They're rarely malignant, and they're also sometimes called hyperfunctioning nodules. And so what happens when they're hyperfunctioning, it's usually this over secreting of the hormones that are, being sort of released normally, instead that it's an uncontrollable amount or improper amount that's being secreted.
So the thyroid has a lot of nodules or parts that are secreting a hormone, and this is specifically one or a couple are misbehaving and going over the top.
Yeah, so it's a gland, and then there's literally like a bump or nodule, almost like a cyst-like cyst-like structure that has its own ability to cause hormones to be released.
It's not normal, but it's not normal. It shouldn't happen, but it's common.
Okay.
If that makes sense.
Yeah.
And just to back up a little bit, because even for me, it's like every time, we hear about the thyroid, you kind of just take for granted that you know what it does.
Yeah.
And I don't know, for a lot of people, it's just so linked to like energy or weight loss. And again, I always find these things are a good refresher even for me. So maybe I'll just go over a couple things.
Mm-hmm. Hit it.
But it's so T4 and T3 they're chemical messengers. They affect literally pretty much every cell in the body. All right. They affect the rate at which the body utilizes fats and carbs. More specifically, which I found again was just really interesting. So it stimulates the breakdown of fat and increases the number of free fatty acids. Okay. So the thyroid hormones can actually, when they're functioning properly, decrease cholesterol levels. So I thought that was, again, something new always comes up when I look at this.
Always a tie-in.
Yeah. And thyroid, I don't want to go like too deep into it here, but has so much to do and so much interplay with your hormones. Both your sex hormones that we always think of when we use the word hormones, testosterone, estrogen, but also with your stress hormones like cortisol. And in fact, like TSH, the chemical messenger that your brain sends to stimulate thyroid production, is blunted by glucocorticoids and by cortisol. So there's always that interplay of what's going on there. So again, it's, metabolism, your heart rate, it helps control your heart rate, your energy level, because again, it's metabolism, the link there, your digestion, body temperature, and even mood. So when you look at all the things that it ties into, it's pretty incredible.
Right.
Yeah.
Yeah. And then just to break it down, hyperthyroid or hypo, what then happens when it's overactive and hyper, your metabolism speeds up, which for some people, that's not a bad thing, but it's all about the balance because you can also get a racing heartbeat. You're getting all the effects of it being too high, not just ones you want.
Got it.
So weight loss, yes, can come into play. You get hot, you get thirsty, you get diarrhea because it affects digestion, anxiety, restlessness, shaky, sweaty, all those things. Hyper, it's all those opposites. Metabolism slows, you gain weight, you're tired, you're fatigued, you're sensitive to the cold, constipation, dry, thinning hair, worse mood, and instead of like the anxiety or restlessness, you get more of the memory and concentration problems.
Wow.
So those are kind of the two, in the most broad sense, hyper and hypo, what the manifestation of that is.
Okay. And so she's got hyperthyroidism, so it's overactive. but it's subclinical. So it's not over the top. It's not horrible. It's just these specific nodules that are misbehaving themselves and causing this, presumably.
Yeah. So when looking at subclinical, just again, from more of a definition standpoint, what that means in this case is low or undetectable serum TSH. So Joey mentioned thyroid stimulating hormone. So this on your hormone panel, your thyroid blood work, you're going to see a very low or undetectable amount of TSH. To complement that, you're probably going to also see a normal or elevated T4 and T3. But usually you'll have this blood work done if you're symptomatic or you notice a lump near the Adam's apple, something along those lines. But when you're looking at subclinical in this case, you may not have overt symptoms, but it's really referring to, the characteristics of the blood work. Like you don't have an overt increase in T4 and T3 that it's so high that's, something must be done about it. It's just more or less its own category.
Okay. All right.
I don't know if you have something to add to.
So there's a lot of different directions. I think though, the whole subclinical aspect, I think like Dante was getting at, typically what you see then, because TSH again is the messenger from the brain to stimulate more thyroid production. So when that's really low, it means that the feedback it's getting from your body is there's enough circulating.
Yeah.
So the signal is not sent from the brain via TSH to make more. Because that's dictated by the levels really low of the TSH. So you would expect that the T4 and T3 would be high.
Right.
But it's not. So it's in the normal range. So I guess what I struggle with, and again, I'm not an endocrinologist, so I'm not saying to do or not to do something.
Right.
But my questions back would be, to the physician, if they want her to go to these measures, methimazole or radioactive or removal, but she's in the subclinical range, her actual hormones aren't high. So there's an autoimmune thing probably going on here, but I would want to know, what her symptoms are and if treatment is necessary, given that she doesn't have actual symptoms and manifestation of this.
Yeah. And we're definitely, I know we'll get further into more treatment stuff, but from that perspective, what I gather is why they're more apt to aggressively treat something like that would be age, male or female, those sort of factors that would make you a better candidate. So, they know because there's in subclinical hyperthyroidism like this, there's an increased risk of AFib, there's an increased risk of heart failure, increased risk of cardiovascular and all-cause mortality.
Wow.
There's a chance for decreased bone mineral density, increased risk of bone fracture, especially in post-menopausal women. So I guess it's
even at subclinical levels.
Yes. And so these are all associative, ways to look at this. But at the same time, I guess if you fall into those categories, if you're over 65, if you have osteoporosis or you're on the border or you have heart disease or you have a history of heart disease, I guess that it just leaves the door open to say, if you're sitting in this subclinical hyperthyroid range, we have a conversation to be had on whether or not, treatment would be beneficial. If it's not showing up as like, we need to overtly treat you, we just know we have this set of risks that we have to kind of parse through. The other thing too, up to half of all people have at least one thyroid nodule, although most people don't even know about it. They can be caused by a multitude of different things, but reassuringly in this case, about 95% of them are benign and they're caused by non-cancerous conditions.
Okay.
So just to, the cancer things sort of.
Yeah, we're also assuming that typically they'll do like a fine needle biopsy.
Mm-hmm.
It could be done really not just outpatient, but right in the physician's office.
Wow.
Really because of how superficial that the gland is and the nodules are.
Yeah.
It's not, just some of those things are for their physical distance and what you're going through, and it can be done pretty easily. So we're assuming that that's been done.
Mm-hmm.
Before they're talking about.
So we're proceeding assuming as if she does not, God forbid, have cancer, given what she's brought up. The one key thing too, and just don't want to go over, is really hyper or hypothyroidism is typically caused by an autoimmune condition. So it's just the manifestation of it. If certain antibodies are going to be more stimulatory, that leaves more to the Graves' disease, which is more of the hyperthyroid. Others are going to be more blocking function and blocking thiamine uptake by the thyroid. That's going to lead more to the Hashimoto's and the hypo.
Okay.
So let me get her exact term here. She said Graves, etc., has been negative.
Mhm.
So what I'm assuming she means is that her thyroid antibodies were negative. That would be something that would be maybe a question to her, would be her blood work. Because if that's not referring to maybe her doctor said she didn't have Graves because she's subclinical.
Yeah.
And maybe they didn't test or that she's not mentioning the antibodies. That just gives you a little more information maybe in what you can do and how you treat it. Because if there's, there are ways, not black or white, 100% effective ways, but there are ways that you can help the body function and,
Sure.
tamp down the autoimmune issue here, regulate it better is a better term. Then maybe especially because she's subclinical, maybe there's some things that can be done there.
Okay.
But we don't know that for sure. I'm just intimating that's what she meant, but it very well may not be.
Well, then that's probably where we need to go next. What is the solution? I mean, it sounds like methimazole.
Methimazole, yeah.
There we go. Radioactive iodine, removal of the thyroid. These seem like pretty extreme solutions if it's subclinical. Granted, it sounds like there's a reason for that, but it does. Those are certainly removal. That's an irreversible solution.
Yeah, I think for her, methimazole, because of the way it works, it blocks uptake of iodine into the thyroid, and especially because she's subclinical, it's going to slow her metabolism. It can cause some weight gain. Again, largely in her case, she said, "Hey, I don't want to do methimazole, but her TSH is where it is, but and her T4 and T3 are really high." Then you say, "Hey, you're going to bring it down to normal levels. You're going to feel better in that sense. You're not going to have that anxiety or that rushing heart rate." But I would be concerned for her that she's going to drop potentially down into low normal or low, given that she's subclinical. So that would be a concern. Also, you do have to monitor kidney and liver function with methimazole. Low blood sugar can be an issue. And also I'm not sure the mechanism here, but shortness of breath also can be an issue as well. So the drug is used a good bit, but again, I just always feel bad for people if they're in that subclinical state or in that maybe like that wait and see approach to maybe do a drug that in her case is probably going to cause at least some negative feelings regarding the weight loss, metabolism, etc.
Yeah.
Makes sense.
And even just so, these all great points, these kind of questions are interesting to talk about too, because we're not going to have some groundbreaking recommendation to send back to her. That's just the reality. This is something that needs handled by an endocrinologist. It's complex. Subclinical, hyperthyroid, Graves. What about the antibodies? I mean, she's given us she sounds very health literate in the questions that she's asking.
Right.
You know what I mean? But I guess the goal in talking about a lot of this is like, hey, let's look at maybe why your doctor was more apt to say, let's try methimazole or try the more invasive treatments. You know what I mean?
Yeah.
So in looking specifically, the American Thyroid Association, who has guidelines for treating subclinical hyperthyroidism. Again, this is for context and again, just maybe the why behind the doctors doing what they're doing.
Sure.
So for example, a TSH less than 0.1, and if you're greater than or equal to 65 years old, they are often going to consider treating you with one of those options that she mentioned. If you're less than 65 and you're asymptomatic, your TSH is below 0.1, consider treating again potentially. If it's 0.1 to 0.4, they're more likely to observe and just kind of see how things change, get some more blood work done every 6 months or whatever. So in this case, that maybe sounds like where she is.
Yeah.
If you are, if you're younger than 65, but you have some of these comorbidities that we mentioned, the heart disease, the more symptoms of hyperthyroid, if we're assuming that, osteoporosis, if she's postmenopausal, all of those, we're not looking at this in a vacuum. We're not just looking at 3 numbers and acting like we know Patricia and know what the best steps are. This is a holistic type thing, and that's what an endocrinologist is trained to do. So
Makes
again,
sense.
you're looking at these different conditions, and you're always just weighing risk. I doubt that the endocrinologist was like, you need to 100% take methimazole because of X and Y, unless maybe she met more of these criteria than we even know about. And so a lot of laboratory cut points and guidelines, they have to set sort of arbitrary thresholds. And the goal is not that you have to hit every single one perfectly. And, she's she's got to follow the letter of the law in this sense. But again, it just gives us context, and you have to understand why the doctor is doing what they're doing. And that I guess that's all I'm trying to
help
to
understand and even help maybe to ask better questions.
Yeah,
you know what I mean, to be more informed. And when you're in that meeting with the doctor, and sometimes it's intense, and you got those couple minutes. Doctor's great, but maybe he needs to get on the next point, whatever it is, and you don't have all those things on the tip of your tongue. Hopefully, this can at least give you some more education about what to ask, how to ask it.
Yes,
absolutely.
Understand.
Okay, so does she have any other options? Are there, I mean, obviously we're making a lot of assumptions here, but what are some other things that she can do to support?
I think that, this is not as simple as, hey, vitamin D levels low, take vitamin D.
Yeah.
LDL is, that's more complicated, but LDL is high. I just want to get this number down. Reggie's rice.
Right.
Those things are pretty black and white. This one is more big picture in terms of what we would recommend. So we're assuming that it's coming from a hyperthyroid or an autoimmune, more accurately, standpoint here.
Okay.
And these are all things that are only going to potentially help and be good for her anyway. These are things that maybe if she is waiting and seeing, if that's what her and her doctor decide, some things she could do in the interim to maybe give her a leg up on what that next appointment is like.
Yeah.
And technically she could do these things along with, but then it's hard to gauge, if there were of any benefit. But gut health. Any autoimmune condition, and it has been linked to, especially this, any type of autoimmune thyroid issue, both hyper or hypo, leaky gut, compromised gut barrier, allows toxins into the bloodstream, can stimulate the immune system in unnatural ways that we still don't quite know. But again, that just raises your likelihood to have some autoimmune conditions, especially if you have a history of antibiotic use, history of H. pylori, all sorts of things that have affected your gut and the integrity and the quality of your gut health. In the past. So supplements would include like N-acetyl D-glucosamine, NAC, L-glutamine, gamma-oryzanol, and high-dose probiotics, at least for a period of time. We have protocols and really, packages even on the website about that. So that's just, again, the theme of that. That is that leaky gut does not fix thyroid issues.
Right.
What you're trying to do is get to the root and as much as you can do naturally, tamp down and regulate, again, more accurately, an autoimmune condition. So along with that, we go like an anti-inflammatory diet. So if you're healing your gut, but you keep inflaming your body with these foods, so whole foods. We're not going to be proponents of a very specific diet, but paleo style, in terms of whole foods, gluten-free, less processed. You're just trying to give your body, the less chance to have antigens or aggravants to the immune system. This is always a tough one, but stress management, exercise, prayer, meditation, yoga, those types of things. Of course, exercise. Because whenever, like Dante had mentioned, when you're hyperthyroid, even subclinically, it can raises your risk of osteoporosis. So weight-bearing exercise is always going to be key. But in this case, you have a specific reason with the osteoporosis risk. But just do watch if you are experiencing, if somebody's watching with true clinical hyperthyroid and they're having symptoms, if your heart rate is really elevated, you're feeling, you get palpitations here and there, just watch overexerting. We get the exercise and supplements, again, more specifically to the thyroid functioning and hyperthyroid, vitamin D, always with the autoimmune conditions, but there are studies. And again, some of these things are they correlated or are they actual cause and effect? But there was a study done in, lost track of it. It was done in Turkey, 849 patients, 440 had nodules, 400 did not. Those with nodules had significantly lower vitamin D levels in general, significantly lower. So again, that could be a correlation of their general health. Is it causal? We don't know, but a lot of smoke around vitamin D in general, as we mentioned before.
Yeah.
So L-carnitine, selenium, probiotics, and then this would need a prescription, but LDN has been shown to help lower antibodies as well. Thyroid-specific antibodies. LDN can help with a lot of autoimmune conditions, but specifically we've seen it with thyroid.
Cool.
So those are the things, at least from a natural standpoint, on Dante has things to add, but that's what I came up with, again, in a general sense for thyroid.
All right. Anything else?
No, I would say that covers it all.
Yeah.
This seems like there's definitely a role for selenium specifically. I know she mentioned she doesn't have the Graves antibodies or, whatever. There are some meta-analyses looking at patients with Graves' disease who are also taking methimazole. And there's within that population specifically, there's maybe some mixed benefit with enhancing the effect of the methimazole and therefore enhancing the effect of the the functioning, of your thyroid gland.
Got it.
That's all. So you start Googling thyroid, selenium, or at least that's worth something throwing out to your endo.
Yeah.
If it is trending more towards Graves.
Another thing to look into.